Welcome. This video will cover advanced care planning during a crisis. It is designed to address key information for nursing facility staff throughout the COVID-19 pandemic. The COVID-19 virus, or coronavirus, is spreading in our communities. Nursing facility residents are at high risk of getting COVID-19 and needing both treatment and support. Symptoms include fever, cough, shortness of breath, and fatigue. We are learning more about the virus every day. Currently, it seems that about 80% of nursing facility residents with COVID-19 will get sick but survive. However, about 15 to 20% will get really sick and die. Residents who are most frail and have the most severe chronic health conditions have an even higher risk of death, regardless of the type of treatment they receive. Knowing our residents is at the heart of providing excellent person-centered care. Talking with residents and families about values, goals, and treatment preferences ahead of time is called advanced care planning, or ACP. ACP is especially important during a crisis like COVID-19. One of the most compassionate things you can do is to help prepare residents and families for medical decisions they may need to make. Otherwise, they are at risk of being asked to make decisions during an emergency without any prior discussion. This is stressful and emotionally challenging. This lack of planning can result in residents receiving unwanted and burdensome treatments. The more severe complications of COVID-19 require urgent decision-making. Advanced care planning conversations can prepare residents and families for these decisions. Proactively identifying resident and family preferences to avoid life-prolonging treatments will help ensure treatments are provided only when they are aligned with residents' wishes. Talking about goals of care and treatment preferences is not always easy. It can be uncomfortable and stressful. Residents and families may need help in identifying their goals. Right now, they may be afraid because of what they see in the news or because they are not allowed to see each other due to COVID-19 visitor restrictions. They may already have family or friends who are sick with the virus. It can be hard to know where to start. Some helpful questions you can ask include, you know this virus is going around. Have you thought about what it means for you? What goal of care is most important to you now? Not many older people who are sick enough to need a ventilator to breathe will survive. If you get a bad case, would you want to go to the hospital and potentially be treated in an ICU or on a ventilator? Finally, reassure families and residents that we will do our best to honor their preferences. The Goals of Care framework identifies 3 general goals of care. Understanding which goal is most important to a resident and/or the family will help them make treatment decisions that reflect these goals. Prolonging life is about focusing on the care most likely to help the person live longer. Maintaining function is about focusing on care most likely to help the person stay strong and do as much as possible independently. Comfort care focuses on care most likely to improve the person's comfort level and quality of life. All residents should have documentation about cardiopulmonary resuscitation or CPR preferences. CPR involves firm chest compressions that are administered when a person's heart and breathing stop. The goal is to restart cardiopulmonary functioning. Medical orders written to reflect CPR preferences include full code or attempt resuscitation and DNR or do not resuscitate. Residents and families are often asked to make decisions about code status, but many misunderstand the likelihood of benefit. Less than 3 out of every 100 nursing facility residents, or 3%, survive CPR attempts. This is both because residents are sicker and because there is sometimes a delay in starting CPR. The likelihood of a resident with COVID-19 surviving CPR is unknown, but experts believe it is lower. The risks of CPR include brain damage from lack of oxygen, broken ribs, and/or organ damage. Residents who survive a CPR attempt will also likely require intubation, ventilator support, and ICU level care. If the main goal is to prolong life, CPR can be attempted if the person's heart and breathing stops. However, if the resident and family's main goal is to improve comfort or maintain function, resuscitation should not be attempted. We should reassure residents and families that we will do all we can to honor their preferences. However, in light of COVID-19, there may be factors outside of our control, such as hospital capacity or ventilator supply, that may limit options in some circumstances. Another important decision is whether or not to go to the hospital. Hospitalization includes hospital care for evaluation, stabilization of certain medical conditions, or treatment intended to prolong life. If the resident and family's goal is to prolong life, the hospital may be the right place to get treatments that are only offered in that setting. If the goal is on maintaining function, hospitalization may be appropriate for selective treatments. If the goal is focused on comfort care, hospitalization should be avoided unless intensive comfort interventions are needed that cannot be provided with the available resources in place in the facility. There are special considerations when making decisions about hospitalization as a result of COVID-19 that are relevant for all residents, whether or not they have COVID-19. For residents who prefer comfort care, transfers should be avoided if at all possible. Residents with possible or confirmed COVID-19 may be moved in order to isolate them from other residents. Reassure residents and families that there is a plan in place to treat residents in place for symptoms, including cough, shortness of breath, and fever. For those with the goal of maintaining function, transfer has some additional risks due to COVID-19. Residents who transfer may not be able to return quickly due to the risk of exposing other residents to the virus. If the goal is prolonging life, we should assure residents and families we will do all we can to honor their preferences. As noted before, there may be other factors outside our control, such as hospital capacity or ventilator supply, that may limit options in some circumstances. Documentation is important to help ensure the care team can access information about the resident's goals of care and treatment preferences. This makes it possible to provide treatments that are in alignment with the identified goals of care. If a resident transfers out and the EMS and emergency department providers cannot find the resident's advanced care planning documents, the resident's preferences may not be honored. There are two kinds of advanced care planning documentation tools you can use to record treatment preferences: advanced directives and medical orders. Advanced directives provide information about residents' preferences. The living will provides information about the resident's end-of-life treatment preferences. The healthcare proxy or legal representative or power of attorney for healthcare identifies who is authorized to make decisions for the resident. Medical orders reflecting preferences are immediately actionable. They include orders about resuscitation, hospitalization, intubation, and pulse forms. These orders should be written to reflect current treatment preferences. The pulse form is used to document treatment preferences as medical orders. Key features include it is used to record treatment preferences as actionable medical orders that EMS can follow. This is especially important if the resident does not want to be intubated or resuscitated. Pulse permits documentation of preferences to have or decline treatments, and it transfers across treatment settings with residents. Most states have a program based on this model, though the name does vary by state. See pulse.org for more information. Sending copies of ACP documents with residents must be a high priority when transferring to another facility or the hospital. Be sure to keep a copy in the facility in case the documents sent with the resident are lost. Quick changes in care settings and visitor restrictions make it hard to ensure information about a resident is known to healthcare providers. Guidance or orders that treatment should be withheld need to be with the resident. This increases the likelihood preferences will be known and followed in an emergency. Be sure to include the name and number of the resident's healthcare proxy, as well as other family members as a backup. It is helpful to have a conversation guide in front of you when you approach residents or call family members for advanced care planning discussions. The Calmer Conversation Guide was developed by experts in healthcare communication at VitalTalk to support planning ahead. We adapted it for nursing home residents. It is one of many tools you can find online to support your conversations with residents and families. The steps include the following. Start by checking in. Ask how the person is doing. Second, ask about COVID. This is on everyone's mind. See what they are thinking. Listen. Next, motivate them to choose a healthcare proxy and identify their primary goal of care, prolonging life, maintaining function, or comfort care. Expect emotion. This could happen at any time. This is natural. Acknowledge it. Finally, record the discussion in the medical record to ensure the person's preferences are known. Use polls if available and appropriate. In summary, advanced care planning is essential for person-centered care in the best of times. Now, more than ever, it is critical as we face unprecedented challenges because of COVID. Identifying the overall goals of care can help guide resident and family decision-making about specific treatments. Record these preferences using ACP documentation tools and send this information with residents upon transfer where the information may be lost. Finally, there are tools to help you. Use a guide during the conversation. There are many available online. Thank you for watching this webinar. I am Dr. Susan Hickman, and I developed this training with my colleague, Dr. Kathleen Unroe, from the Indiana University Center for Aging Research. We hope this information is helpful to you during this difficult time. We are here to help you and welcome any comments or questions you may have.